Take your seats again, please. So thank you all, and welcome to the final session of the day. I know it's been a kind of rattle through a huge amount. So for the next session, I'm delighted to welcome Professor Hugh Watkins, who is well known to many of us and has really kind of fundamentally taken us through the development of understanding on a breadth of cardiomyopathies, particularly looking at the molecular genetic analysis and understanding of cardiovascular disease as a tool in defining disease mechanisms and therapeutic targets. So he's very well known, and obviously he's one of the gurus that I work with locally. But I welcome Hugh to really take us through this next talk, because the future of cardio-genomics is here, and we either run with it or we get left behind. So thank you very much, Hugh. Over to you.
Thank you, Eleanor. Very kind. And thank you for accommodating my abrupt switch to doing this virtually, particularly to your audiovisual team who've done a great job. I will just share my slides. Let's do that. Good. So you should have my first slide there, I hope.
We do indeed. Thanks, Hugh.
Perfect. Thank you. So look, this is a very broad topic you gave me, and I think it's timely to focus on one particular aspect, and that is a question that has come up several times during the day, and that is, are we poised to be able to actually cure genetic cardiomyopathies? And I think this is timely, partly because we have some very new, amazing precision tools that make this at least a theoretical possibility, and partly because there's very clear evidence of unmet need. And as some people will know, trying to come up with genetic cures for cardiomyopathies is the subject of a bid that I lead for the British Heart Foundation Big Beat Challenge. The results of that are not known yet, so I'm going to try and look at the wider field rather than focus specifically on that proposal. So we don't normally talk about this term cure in context of cardiomyopathy. And to be clear, what do we mean by this? To me, a cure would be to deliver disease-free survival. You could debate whether this was a permanent end to a condition, something surgical, removing the possibility of it, or whether it was an intervention or a repeated intervention that gave you indefinite remission. I'm not sure the difference is very important. I think what will matter to the patient is confidence that you've dealt with it and it won't come back. And this is how you would think about cancer. But I think it's actually how patients may also, who've got a severely threatening form of cardiomyopathy in the family, they may come to be able to think about the cardiomyopathy. So why do we need a cure? It's because our current therapies, good as they are, aren't good enough. We have done very well with handling sudden death risk and arrhythmia. We've got some quite good interventions, some quite good medicines, but we don't have anything that is fundamentally disease modifying. So if you have a patient who is facing progressive pump failure, there's very little you can do. And we know that that brings a huge burden of symptoms and then the complications, atrial fibrillation and heart failure. And if you're in a family where this has happened to someone, everybody else who's got the same inherited condition lives under a burden of fear that it could happen to them and the doctors won't be able to do anything apart from possibly offer a transplant, which is clearly not the remedy that you want. So I think we need to think really seriously about whether we can now come up with cures that would modify disease progression. And importantly, I'm thinking that this progressive pump failure aspect is germane to all of the cardiomyopathies. This is an image from Cardiomyopathy UK. Clearly, dilated cardiomyopathy, restrictive cardiomyopathy, pump failure is front and center. But actually, it's a very major problem, and this came up earlier in HCM, and it can be in arrhythmic cardiomyopathy also. And collectively, these are really common diseases. We could debate about whether it's 1 in 250 or 1 in 500 in aggregate. It just depends on what definitions you use, where you make the cut. But the numbers of patients are really substantial. We know it's serious. For sure, yes, these are progressive in later populations, but they're actually very visible in younger populations where other heart diseases, where half of all transplants, for example, are done for cardiomyopathy. And because they're common and serious, the healthcare costs are huge. And that'll be important if we want to come up with new therapies that will at least initially be expensive. We need to know that they can be cost saving. And then I think it's important to stress that the familial nature makes these disorders much worse. In any family where an individual has had a bad outcome, others live under the shadow of that and are fearful of their future as well. And this, I think, brings familial disease very much into an area of major unmet need. So just to turn to the sort of the heart failure aspect of, for example, hypertrophic cardiomyopathy. So I've got a slide here exactly the same as the one that Perry showed earlier. This is a very big deal. If we look at the heart failure composite, this was in the SHARE registry, and it's quite a hard endpoint. It's transplant, LVAD, ejection fraction below 35, or NYHA 3 or 4. You see, depending on age of onset, this relentless exponential increase in endpoint. And it's about 0.5% a year. Same for AF. So if you are unlucky and you start to manifest cardiomyopathy early, you are very, very likely to have a heart failure endpoint. So I completely agree with Perry in his editorial that this is a lifelong disease that requires continuing treatment. It's not just DCM. We can also see that there's very great unmet need in certain families that just have severe forms of cardiomyopathy. This is a family tree from a patient advocate who's a member of our BHF bid, who has a rather well-known mutation in the myosin heavy chain gene, and it's caused devastating problems in the family. As you'll see, there are quite a few young sudden deaths, less recently due to ICDs, but there are 6 transplants. Often at early ages and not always successful. So some individuals have had a transplant, but have only made it for a couple of years after that. So we all know that there are other cardiomyopathy families where the disease is mild. And clearly, if you're doing genetic therapies, you have to look at the severe end. But families like this are out there, and we can't do very much for them. Because the interventions that we would think of that come under a banner really of gene therapy are quite serious and may have unknown risks, we were keen to work out whether patients would have appetite and interest in this. So we produced an educational video that explained what the procedures were likely to be like, and we did a questionnaire, and we circulated that through Cardiomyopathy UK to members in the UK with diverse cardiomyopathies. And Joel Rose, who ran this, said that he got a much brisker, many hundreds of replies in that first week than in another clinically typical clinical survey. And if you look at the data on the top of this slide, how concerned are you that your cardiomyopathy might progress in the future? Well, the answer is a surprisingly and alarmingly large proportion of these patients are genuinely worried. It's a much bigger number than I think I see in clinic. And that probably just means that patients don't tell me all of the burden of concern that they carry. So that was important. We went on to describe scenarios and ask, in a particular scenario, would you think about possibly taking part in a gene therapy trial? And the answers are quite striking. So in an adult who's got limiting symptoms and has been told their heart's getting worse, the overwhelming majority would be very interested in something perhaps drastic, but potentially more definitive. Surprisingly to me, even in an adult with mild symptoms, but told they might need an ICD, which from a cardiology point of view, I might think, well, they're sorted. They don't feel sorted, and they too would be very interested in disease-modifying therapy. And then a parent, notionally, of a young child who doesn't even have symptoms, but where an older sibling has succumbed and died, again, a high level of willingness to consider genetic intervention. So the patients are telling us very clearly that they want us to do better than we currently can. So if there is need, can we be optimistic that we can do something about it? We can, and it's precisely because of these remarkable precision tools that allow us to fix the underlying genetic defect at the level of the DNA in the cells in the heart, or at the level of the RNA that those genes express. And these are new tools, but they absolutely do give you the potential that you can treat the root cause of the problem, and that in treating an affected person, you could achieve cure. Or even more, and perhaps more important the longer term, if you deploy that intervention early, for example, in a young person carrying a pathogenic mutation, you might expect to prevent disease from ever occurring. And that would be truly transformational for cardiomyopathy. And actually, if we can do this, it will be part of something bigger. So at the moment, only a subset of proteins make good drug targets. But if you can target a particular gene and edit it, or dial it up or dial it down, you can target any gene in the genome. So that's a huge amplification of potential therapeutic targets for heart disease. So if we can do this in inherited heart disease, this becomes very important in acquired forms of heart disease also. Why do we think it's timely and that we think this might be achievable in a 5 to 10 year frame? Well, it's because we're building on some very solid foundations. So a lot has been discovered. Cardiomyopathies are a well-worked example of a monogenic or largely monogenic disease. We know the genes involved, and it's important to say that in the setting of thinking about genetic medicines, we're only talking about that part of cardiomyopathy that is caused by a monogenic single pathogenic variant, albeit with variation on top. We're not talking about therapies for common, perhaps polygenic disorders, but it's the monogenic end that's the severe end that has the high unmet need and the transplant risk, etc. We know about the types of mutation, and in particular how they operate. And I'm not meaning here the impact on, for example, a myofilament or on an ion channel, but I'm meaning, are they dominant negative, by which one copy interferes with the normal one, or are they haploinsufficient, by which I mean you don't get enough protein. And you have to know that to come up with an effective strategy. We're pretty good at working out how we would measure cardiomyopathy disease severity in a given patient. And we do this largely by imaging, but we need to get better at it. And we'll need it because we'll need it for endpoints in early phase trials, and we'll need it for case selection. We know that not all patients with cardiomyopathy will go on and get severe disease at all. So we have to become better at identifying the individuals who are on an adverse trajectory, who do justify intervention. And then other scientists outside our field, but fortunately members of the consortium that we've put together for the VHF bid, have worked out how to precisely edit genes, and I'm going to show you a little bit of that, and have got much, much better at delivering viral and non-viral vectors for delivering these genetic medicines to cardiomyocytes. It's not going to be easy, and the reason for that is that we have heterozygous disorders that are autosomal dominant. So this isn't a case of a missing protein that you replace by gene therapy. We have two different mechanisms, they're alternates, that we have to tackle. So for many of our cardiomyopathy genes, classically something like myosin heavy chain, for example, we have a missense mutation that's dominant negative, and the mutant copy interferes with the function of the wild type copy. So to fix that, you have to selectively silence or correct the mutant copy and leave the wild type one alone. And then there's another group, for example, MYBPC3 HCM or Titin DCM, where we have a loss of function allele and it's a haploinsufficiency. And there you need to upregulate the gene protein. And there are challenges that you would spot quite quickly when you thought about embarking on any of these. But actually, I will try and show you that those challenges aren't quite as difficult as we thought. So one of the challenges is, well, in the silencing, when you target the selective mutation, if you had to do each and every one, that sounds hard. And another would be if you had to get rid of all of the mutant protein, that would sound hard also. But I'll show you that neither of those turns out to be true. And then in the gene supplementation, which I won't really talk about today, we've got the problem that many of the genes that we're interested in are far too big to put in the vector. So you have, in fact, to engineer the way they're expressed rather than package them and deliver them. But actually, the same technologies will do that. So let me touch on these selective allele-specific silencing or correcting strategies, which I think is where things will go first. So this is a schematic that shows two copies of, let's say, the myosin heavy chain gene, one from mum and one from dad. And in the top example, we have a point mutation that causes HCM, and in the bottom, we have a point mutation that causes DCM. And you'll know well, these mutations are scattered throughout the length of these genes and proteins. And if you had to come up with a correction strategy specific to one point mutation, and then market it, you might have a problem because it wouldn't likely be relevant for more than a small number of patients. That makes it not commercially viable. But it turns out you don't have to do that. What you do instead is you create your silencing or editing tool to target either the C or the T, in this example, variant of a common silent, i.e. synonymous polymorphism. And then when a patient comes in, let's say with R403Q, you ask, is that mutation sitting on the C or sitting on a T copy? And then you go to the shelf and you get your genetic therapy for taking down C or taking down T. So if you make a pair of tools, one does C and one does T, that pair of tools will target 50% of all patients with myosin heavy chain mutations. And that's a very big number. So this strategy absolutely is commercially viable. The second hurdle is if you had to completely get rid of the mutant protein, that would be hard, particularly if you had to do it selectively. But we know that you don't. On the left two panels, you've got histology and a gross heart of a mouse model created by John and Cricket Seidman that has a well-known myosin heavy chain mutation and quite a good HCM phenotype with hypertrophy and the fibrosis that you see with that blue color. Those mice, treated early postnatally with a single treatment with an AAV9 vector RNAi silencing strategy, get a rescue, which is a complete rescue that goes out at least until adult life of the mouse. No hypertrophy, no scarring, no obvious sequelae, just with a single remedy, a single shot. And the most important thing about that result is that the rescue is achieved by only about a 25% reduction in the mutant myosin. So you don't have to completely get rid of it, which is good because that would be very hard. You just need to knock it down a level, and then there are compensatory mechanisms that kick in and the heart stays normal. Could you do this in patients? Well, we think that you could. So you will need chemistry. Let's say here I'm using an antisense. You could look at RNAi, but let's say an antisense that can selectively target one version and not another on the basis of a single nucleotide difference. And the example shown here is chemistry made by a company that's a partner in the bid, Wave Life Sciences. And the example, this is Huntington protein in human neurons in culture. And the wild type one in green is not affected by this particular ASO, but the mutant one in blue is knocked down by about the amount that we needed to achieve in the mouse to achieve rescue in the heart disease. So clearly we need to move from a neuro example to a cardiac one, but this molecule is already in clinical trials in patients. We will be using antisense silencing quite a lot in cardiology quite soon. If this works, this could come to patients quite quickly. It clearly wouldn't be a definitive lasting therapy. For that, you would need editing. So let me briefly touch on what editing would look like. The Venn diagram shows you that most of the mutations we have to tackle are point mutations. CRISPR-Cas9 is not a good tool for this. CRISPR is good for deleting genes, for chopping them in bits, not very useful for genetic therapy in patients because of off-target effects, and not very good for our specific correction needs. So instead, we need CRISPR version 2 or version 3, and in particular, this would be base editors. So the examples I'm showing you are base editors created by David Liu at the Broad, who's also a partner in this bid. He and others have used amazing chemistry to create enzymes, sometimes derived from natural enzymes, but the one on the right, the most useful one of all, the ABE, are not derived from any natural enzyme, but actually created by directed evolution in the laboratory. And that particular editor, because it will take a T back to a C, will correct the most common human mutation, which is the C to T transition in the blue quadrant in the chart. So this enzyme was built because we need it for human disease. And its efficacy has been demonstrated very spectacularly in David's lab. And I'm going to show you an example here, which is progeria. So interesting, because it's a lamin point mutation, and we know quite a lot in our world about lamin point mutations. Mouse model on the left. So mice with the progeria mutation make progerin, and they all die very abruptly at this premature age. Again, single treatment, AAV9 with the ABE editor that David had created, targeted that single point mutation, has impressive rescue of longevity. And it does it, again, by only correcting a subset of cells and by substantial but not complete knockdown of progerin. So that's a very encouraging result for us. You don't have to treat every cell, absolutely. And the mouse results are very impressive. This is the poor mouse, the wild type, excuse me, the mutant, non-treated mouse at about, well, just before they all begin to die. And then here we have mice that have been treated at 11, well, they've been treated early before the 200 days, and here they are 11 months old, running around basically very well. So this is an impressive correction of a single point mutation. And what's important about this is not like making a new small molecule drug, which is a very slow process. This is extremely rapid science, because you can program the enzyme to do what you need to do. So proof of concept in cells, through to proof of concept in mouse models, published in Nature, partnership with Beam Therapeutics, meet with the FDA, and now planning first-in-man studies in progerin and human progeria in just over 3 years. So this is a rapid acceleration, which we now really need to see in our world of genetic heart diseases. So whether we're going to be doing silencing, for example, the allele-specific approaches that I spoke of, or editing, we have certain concepts we need to consider that apply to all of these approaches. One of them is we're only fixing the heart. Current ethical frameworks don't allow us to prevent germline transmission, so we will just be treating at the moment the current generation. We clearly need to balance risk and benefit. We need to start these studies in patients with advanced and severe disease, but clearly the goal is to show that they're safe and effective and begin to deploy them much more early, ideally as a preventative tool where the benefits will be a lot greater. But we fundamentally believe that it ought to be possible to stop progression, to cure disease, and actually to prevent disease, which is where you want to be. And then again, it's a programmable technology. Once we can show it be feasible in the heart, it really opens the door to many, many other therapies. So if I just finish now on just a sort of a summary slide, which tries to put this in context, because the whole title was the future. This ought to work very well in the cascade. We are, as a community, already very good at cascade screening in families with Mendelian cardiomyopathies for preclinical diagnosis. And we create large cohorts of mutation carriers, many of whom won't have severe disease, but some of whom will. We are getting better, and we need to get better yet, at working out how to work out which of those individuals are really heading for trouble and need therapy. The rare variant absolutely is a major driver. The polygenic risk score layers on top. And we have quite good, but probably need to be better at picking the early onset disease, where you're just beginning to accrue overt pathology in the heart, which is the point at which these therapies should be deployed, to work out who's on a bad trajectory. But at that point, I think the goal will increasingly come to be to correct the fundamental defect, to try to cure, to try to prevent, rather than just to ameliorate symptoms as we currently do at present. Good. Well, that's my rapid view of the future. I hope that I'm correct in being optimistic about that. I will stop sharing slides and then be very happy to take questions.
That was terrific. Thank you very much for a wonderful way to begin to bring to a close a really great day. But I'm sure there are questions for Professor Watkins. Are there any in the room here? I haven't got any on the chat yet. Tessa, would you like to take the mic?
Hugh, how did you... Is it turned on? Sorry. At the bottom, there's a little red button. Little red button at the very bottom. Hello, perfect.
Yeah, so how would you give this treatment? Because if you look at the spinal muscular atrophy, it's neuroendocrine, which is intraspinal. Would this be intracardiac, and do you have to give it very early, or can you give it at the onset of symptoms? Progeria is such a terrible disease, you can pick it up very early, but you wouldn't really want to treat a newborn baby?
So yeah, two sets of questions there, Tessa. So route of administration will be totally driven by which of these agents looks to be effective in which setting. So the antisense oligos that we have shown to be allele specific in rodent models actually have been delivered systemically. So route of administration there is probably subcut injection. And that's obviously nice and easy to do. What it won't give us is a definitive or long-lasting cure. That would need repeat therapy. But that won't be very different from what we'll be doing for PCSK9 to manage LDL cholesterol. But the editing tools will need single delivery, probably viral vector or non-viral vector delivered. The hope would be to do it systemically, and there are ways that you can make that safe. But cardiologists are very good at retrograde and antegrade perfusion of the heart. And if you're doing a one-off intervention in a young person that would prevent them developing cardiomyopathy, take them to the cath lab, I think would be fine. Time point for intervention will, I think, evolve. We'll have to start these explorations in advanced disease. But ultimately, you want to bring that early. And that's why we need to be good at using rare variant, common variant genetics, biomarkers, imaging biomarkers, to spot people who are just beginning to manifest phenotypes at young ages. And that might well be childhood or teenager, but not newborn.
Are there any further questions? I was wondering if there's any concern about any kind of off-target effects or any side effects, or is it too preliminary to know?
No, there's lots of challenges there, and that's why we pitched it to the BHF as a grand challenge. And I don't imagine a cardiac group will be the one that will get to that to solve that first, because this field is more advanced in neurogenetic disorders, in skeletal muscle disorders, some metabolic ones, and it's quite nice in a way to be following in 2 or 3 years behind, because off-target effects will be very important. Once we are clear that we're not using CRISPR, and I don't think we will be, I can't see much room for it. All of the base editors, the prime editors, don't do double-stranded breaks. So the level of concern is much lower. We have good ways of targeting the heart, including cardiac-specific promoters. And the lovely thing about the heart, it's a post-mitotic organ. You know, we don't see cancers in our heart muscle. So compared with liver or bone marrow, we're actually in a fairly safe space. So yes, there's lots to do to prove you don't have off-target effects, but I think there are reasons to be optimistic that the heart might actually be an easier challenge than some of the other organs.
That's very positive. Any other questions?
I have a kind of practical question, I guess. We're a long way from it because it's not in human use yet, but what sort of, bearing in mind the burgeoning pressures on our resources and things, what's the sort of cost attached with this potential treatment?
It's interesting, Els. The materials are not fabulously expensive. So the reason these treatments that are getting close to the market or on the market are amazingly expensive is that's the cost recovery model for all of the research. So going back to the SMA that Tessa brought up, you know, it's an alarmingly expensive treatment that, you know, is available, but it's a bit scary. An issue that pertains to cardiomyopathy, which I think should help us, but has its own hurdles, is that the numbers of patients are very, very much larger. So economies of scale would allow a company to have a viable model to cost recover for all of their invested research with a much lower margin or increment per patient. So at least in theory, you can postulate that this wouldn't be more expensive than the sort of procedures that you currently do, for example, a cath lab procedure to intervene on an alcohol septal myectomy or something like that. So not cheap, but if you look at the total healthcare costs of severe cardiomyopathy with all the follow-up and all that it entails, I think cost effective.
Very exciting, a very exciting arena. So any further questions in the room? So we haven't got any questions online, actually, Hugh. It's probably because it's such a novel area that's fast moving that, you know, actually gives another few years' time. How long do you think it will be before we really are, I mean, I guess the human trials will be starting before too long.
It'll depend on the modality. So the one that you could imagine, if it can be shown to work, to come through most quickly, would be in allele-specific antisense. You know, cardiologists will be all familiar with antisense long by the time we get there. We'll be using it for PCSK9. We'll be using it for the amyloid. It's harder here because we need the allele specificity. But if that can be achieved, and the chemistry is amazing, and it looks, I mean, it is working in animal models, and there are human trials. If that proved to work, that can move quite quickly. And then you could imagine doing trials in a patient in, I don't know, 4 or 5 years' time. If it turns out that for other cardiomyopathies or in general, it can be shown to be more tractable with editing tools, that's further, because of the nature that it's a one-off. The burden of proving that it's a safe thing to do is higher. I think it will be in a 5 to 10 year window, and I'm a bit of an optimist, so that's the sort of that'd be my view of it.
Fantastic, thank you. So I think with that, we'd like to thank you very much for a very eloquent keynote speaker session this afternoon. Thank you very much, and for overcoming our tech barriers, which we've certainly surmounted, I think, today. So yeah. Thank you, Hugh, and thank you to the audience as well for listening. And I'm loving the emojis in the background. I think our virtual attendees have been enjoying those all day. So I'd like to hand over to Jan now to take us through to kind of wrap up, really. There are some questions still online from the system, but I've taken some screenshots and we'll try and get some answers through to you as a summary email. But I think in the interest of time, we will continue to wrap up now. So thank you very much, Jan. Over to you.
Thank you, Eleanor. So we just, you may have realized that Catherine, Mercer and Juan Kasky, who couldn't actually join us, but and John Dean, who was online, managed to get online, who's been with us, have been doing the abstracts and marking them. It was an amazing selection of abstracts, a really high standard, which I found incredible, given that we gave you an extraordinarily difficult timeline to get them in. So thank you very much for submitting those and taking the trouble to make the poster. And I guess we've got to do this in reverse order, Catherine. So we have a runner-up, and the runner-up is... You need to do the drum roll.
Oh, okay. You can tell we haven't rehearsed this. But yes, the runner-up.
The runner-up goes to Julian Ormerod for calcium release deficiency syndrome. I don't know if Julian is still here. Julian, I think you deserve this because you've found a reason for us doing diagnostic EP studies again, which we completely don't do anymore. We're sort of redundant. So I think that's brilliant. You are, Catherine.
Great, congratulations. Thank you very much.
And the winner goes to,
Drum roll again.
and the winner is Hannah. Hannah Green. She's virtual. Oh, I don't know if you're still on there, Hannah. Maybe you've got a glass of wine in hand. And so refinements of hotspots in long QT syndrome.
We'll make sure that Hannah gets this.
Yeah. So we just wanted to finish. I've had an absolutely fabulous day, actually. I really enjoyed it. I think the talks have been... Oh, is Hannah there?
Hi.
Hannah, well done. So, yes, I've had a fantastic day, and I think the talks were just great. And I think they were fantastic because they were from the UK. And I think we really highlighted all our own scientists and doctors, nurses, the whole multidisciplinary team. So I think that was really brilliant. I really enjoyed that. But more so, I really enjoyed seeing you all. I enjoyed seeing your faces again. And so that was really something. And thank you so much for taking the trouble to attend. I hope you think it's been safe. I hope it has too. I don't want to be highlighted in the newspapers as a super spreader. But do take care out there, because it's a really tricky world. I think just there's a couple of people we need to acknowledge. Catherine and I have been working, well, it's a couple of people we've been working with for this conference. One is Valerie Honoré. Is Valerie in the room? I think she might be outside, actually. Valerie, can you hear us? I know you're listening.
Mel, could you see if she's there? Mel's our treasurer.
Valerie's done an enormous amount of back behind the scenes working to try and help with this cause.
So Valerie helps us all the way through the year, actually, and she's been a fantastic help, often doing far more than her job description. So she really deserves a bit of an applause. And I know she won't like me for this because she's very shy. But Valerie, brilliant work. Thank you so much.
Oh, wow.
Thank you.
So the other person, who can only be described as a complete tour de force on her own, and has been breathtakingly fantastic in doing the conference, is Eleanor. Els, I realised, to everyone else. She came in with enthusiasm and enormous energy that went through all the way to the end, which, including today, but late last night. And Els, we couldn't have done this without you. You were absolutely brilliant. So we'd like to say a huge thank you. And we have some rather lovely vouchers here for Sweaty Betty. And something to drink tonight, because I think you'll need it.
Thank you very much, everybody.
Thank you.
And thank you all.
So thank you once again. I think it's brought us all together. I hope there will be some ideas you've had as a result of some of the talks and some of the discussions we've had today, which will take inherited cardiac conditions further. We need to thank the sponsors. I don't think they're in the room. Is the guy from cardiomyopathy in the room? No. So thank you very much anyway to them. We will thank them by email. Anything else? Thank you to Cavendish. Thank you, Richard, up there, who equally had a bit of a sleepless night. actually, because he was working late. So, and got up very early this morning, so. No one else?
Yeah, round of applause.
Good. Okay, so safe journey home, everyone.
We'll see you next
Thank you for everyone.
Yeah, see you next year.